To celebrate this journey of our founders who inspired and set an example for all of us, we institute the Founders Oration in 2013. Every year, an eminent person who stands as a high example of success renders the Founders Oration. I now request Dr. S. Rajasabhabati, Chairman and Head of Department of Plastic, Hand and Reconstructive Microsurgery of Ganga Hospital, to welcome all of you to this August evening.
Good evening to all of you. It's always a great pleasure for all of us at Ganga Hospital to welcome a luminary in the field to render the Founders Oration and to share the joy of our founders with you. And this is also a form of paying our respect to our founders who gave us a platform to jump. And on this day, we respectfully thank God for all that our parents have done. Dr. Mayo, the senior Mayo of the Mayo brothers, he said, when they asked, what is the best thing you did? He said, the best thing my brother and myself did was to choose the parents we had. I think that if nobody got the opportunity to choose the parents, but then he said, the best thing that we ever did was to choose the parents we had, and I'm sure now that we also could be saying the same thing to both of them. And this oration was set up to celebrate the journey of our founders. And after the father reached 80, and then after that we thought as to what we should do, in 2013 we set up this Founders Oration. And in 2013 we had Dr. Devi Shetty. He was speaking on affordable healthcare, and this series was inaugurated by the Honorable Chief Justice of India, Justice Sadasivam. And this was followed by Mr. Gopal Swamy, former Union Home Secretary, and he spoke on the topic of governance and govern. The idea of it was that we should invite a person of eminence, as Susan told in his address, that they should be standing tall because of their integrity and high achievement, and each one of them justified our expectations. And one of the other things that I told Dr. Bang was, we like to invite somebody who will otherwise have not come to Coimbatore. And that was also another reason. All the people whom we invited, I think they said, for many of them, just their first visit to Coimbatore. And in 2014, we had Mr. Gopalakrishnan, Executive Director of Tata Sons. Tata is another institution which we greatly admire. And he spoke about the Tata values and said, what is achieving excellence? Is it an attitude or a goal? And in 2016, we had Mr. Venu Srinivasan, the chairman of the TVS group, and he spoke on values that build institutions. And in 2017, which also coincided with our 25th anniversary of our Tata starting of a specialty center, we had two people. One is the Subrata Bakshi, who was the founder of Mindtree, and the historian, Mr. Ramachandra Guha. And last year, we had the chairman of, ex-chairman of the Tata Steel, Mr. Muthuraman, talking to us about institutional transformation. So as I said, the thing that we have, idea was, this to be an eminent person who stands as a high example of success, which is achieved through hard work, honesty, ingenuity, social commitment and passion in what they do. I don't think we could ask for any better person than Dr. Abhay Bang, who has been the 2019 orator. And we have been speaking about a few times after lunch, around lunchtime and all that, I will say a few things as to what he should do. He said he qualified as the first in the university in Nagpur, and he stood first in the entrance exams in the PGI Chandigarh. I think PGI Chandigarh, those days in the 70s, I think it's an extremely difficult institution to get through, and he stood first in the entrance examination. And then he did go there, and he was doing his residency for 6 months, and he said after that he just gave his resignation letter because he found that 90% of them who finished PG residency went off to United States, and then somehow he said, I was deeply committed to a place where we are in the rural areas, I think we should go. And he himself asked himself the question whether he is being prepared for that. And he thought his answer was no, and he said he didn't really think a second thought to just give a resignation letter and go back to Nagpur and then study all over again. So that shows is the amount of commitment and passion that he could have. And he also told that another example, the other thing which he said was people who stand for their social commitment and their commitment to the purpose. I should tell another example as to what we feel it fits into that, because we planned this oration in the early part of October. I think early part of October, and we almost, we have printed the invitations, and half the distribution has been done. Suddenly I received a mail from them. He said that I had to represent India in Germany and also had the opportunity to meet, to discuss with the German Chancellor, and I will not be able to come back. But then, if you feel that you cannot change the date, I will cancel the trip. He said that. Then we said, oh no, you should not do that. I think it was also part of talking about Gandhi, and the government was sending him. So he said, but then he said, I am prepared to change that, I am prepared to cancel that if you are not cancelling that. I said, no, sir, you please go, give us another date. Then he gave us another date, and then at that time, he said that we were almost through. Then he said, the Maharashtra elections date have been announced, and we have been standing for prohibition among the tribal people and talking about the ill effects of drinking. And we have been we are fighting hard so that the people of the area, I think the legislators, must not be propagating liquor. And to our dismay, we find that the ruling party has put a liquor baron as a candidate. And then we need to really struggle hard to campaign against that. And they need to get assurances from people that they will not be propagating that. And this time he said, I am cancelling your, even if you printed it, I am cancelling it because this is a lifetime's work. I think a person who was willing to cancel his appointment with the German Chancellor, but then not willing to cancel the thing for the sake of what they have fought for all their life. I think then we again said, so no problem, sir, we'll change the date again. And then here we are, sir. So thank you so much for coming, sir. And I'm sure it will tell us as to what they have achieved. And so I think he stands tall example for what we all of us look for and we aspire for. And we have our chief guest, Mr. Krishraj Vanavarayar. If you had seen the photographs of all the previous times, he has been once before also, he has been our chief guest. When Mr. Gopal Swami was the former Union Home Secretary, was the rendering the oration, he was again so thank you so much for coming. And I always love the opportunity to speak to him. And this time, every time I go, I always think, I should at least catch one word was what he said. And this time, when I went home and gave the invitation and came, I said, I caught this. You are mature only when you are sensitized to the suffering of the people around. And I really asked him, sir, who said this? When he said, so many people have said this. So, but I think it's it stands perhaps so much because we are, as doctors, we are working in a field of trauma, and then there you find we'll always be able to do better if you are sensitized to the suffering of the people. I think you can't put it in no better word as to find out as to what's the quality person a doctor must have. So thank you very much, sir. It's always a pleasure talking to you, and then and thank you for accepting an invitation and being here with us, sir. And I thank all of you for being with us. And once again, I can't be thanking our own doctors and our staff because they are part of the family. But then, as Dr. Abhay asked me, who will be the audience? I said 50% of them will be staff and 50% will be non-medical people. I think all of them are very happy to be with you, sir. And I heartily welcome all of you and hope you all have a very good evening. And on this day, we invoke God's grace and all your good wishes for the continued success of the program and our good wishes. Thank you so much and have a good evening.
Thank you, sir. Where there is righteousness in the heart, there is beauty in character. When there is beauty in character, there is harmony at home. When there is harmony at home, there is order in the nation. And when there is order in the nation, there is peace in the world. Our chief guest for today's evening, Reverend Dr. B.K. Krishnaraj Vanavarayar, is a standing example of the above quotation. Dr. Vanavarayar, an educationalist and one of the most prominent and well-known illustrious personalities of Coimbatore, is the chairman of the Bharati Vidya Bhavan, an organization committed to preserve and propagate wisdom in India Inspired by the ideals of Swami Vivekananda, Dr. Vanavarayar has done yeoman service to spread the glory of India through inspiring speeches and thought-provoking ideas. As chairman of the Divyodaya, an organization committed to initiate interreligious dialogue, helping to the pluralistic culture, Dr. Vanavarayar has worked to promote peace and brotherhood, and the crowning moment of appreciation was when Sir Pope John Paul II invited him to attend the Day of Prayer for Peace in World in the Vatican in 2002, and the speech he delivered was widely acclaimed, and indeed, sir, it was a proud moment for Coimbatore. A recipient of numerous awards and a committed Rotarian, Dr. Vanavarayar was also awarded the Doctor of Letters honoris causa by the University of Avinashalingam for his work on Gandhian ideals. Dr. Vanavarayar is also the president of NGM College and also Kumaraguru College of Technology. We are indeed privileged, sir, to have you as a chief guest for today's evening, and I kindly request you to deliver the presidential address.
Thank you for that nice introduction. Every year, we look forward for this oration, and the Ganga family makes it a point to bring a very outstanding person to speak to us. And this is the 7th lecture in succession. They bring people whom normally haven't come to Coimbatore, but they are great role models. In the present day society, if there is scarcity for anything, it is role models. We speak a lot, but we hardly live accordingly. But the youth of the day look to role models. When they saw one Abdul Kalam, one Anna Hazare, instantly they got attracted. So today we have another role model. If you care to go into the net and try to get to know more about him, and in the YouTube, you can listen to some of his talks and what others had to say about him. Amazing is the man. So we should compliment the Ganga family for having spotted out this gentleman and have brought him here all the way. He had everything to plan for a lucrative career, but he opted to take to service, and that too in a very remote place, in a jungle infested with Maoist influence, he and his wife. This is something very different these days. We normally say, why can't doctors go to village? There are a few doctors here. I know a doctor who came from village to the city, but no doctor wants to go to the village. But he chose to go to a village, and that too, the most neglected village in Maharashtra, and created a base there, and for the last 30 years, almost 30 years, he has been working there. Now, you would like to know how this change happened in him. As I told you, he got 3 gold medals in the university, went to America for further training, came back and straight went to the village. Not only he, his wife as well. She's also a doctor. They fell in love with each other and married, and what was the common thing was both of them wanted to serve. So they are a perfect couple, happily serving in that godforsaken place. And now, I should tell you how this change happened in him. His father was a professor of economics, working in a college at Shevagiram, and Mahatma Gandhi had something to do with that college. And his father was an eminent professor. He got an invitation from US for advanced studies. So his father went and met Mahatma Gandhi and gave those papers to the Mahatma and said, kindly bless us, Mahatma, I'm going to USA to study more about economics. And Mahatma said, you don't have to go all the way there. Go to the most neglected village in India and do some research. You will understand economics better than you otherwise get to know at USA. This was the advice of Mahatma Gandhi to his father. And his father came out tore those papers, travel papers, and decided to stay back and serve in the village. Am I right, sir? You missed all that, Sabhavadi. Then, the story doesn't stop there. He was a young boy playing all the time in the Sevagram ashram, this person. And his time came, he also went to US, as I told you, underwent all the training. He also decided, I should do something like my father. So he too decided to go to the village, and that's a long story afterwards. Then the rest is history. Then he founded this organization, Search, S-E-A-R-C-H. He will tell about all that. I should not get into that. Now, I'm given 10 minutes. 5 minutes, more than 5 minutes gone, I suppose. In the remaining 5 minutes, I have to say something. Bharat Vidya Bhavan's Vice Chairman, my good friend, the senior advocate, Dr. N.V.N. is here. We both decided to celebrate Mahatma Gandhi's 150th birth anniversary in the Bharat Vidya Bhavan. And we brought Ela Gandhi, the granddaughter of the Mahatma, as the chief guest from South Africa. And we honored about 12 most eminent Gandhians in this area, all in the ages of 80, 90, 100, 104. We managed to get a man of 104 also. We celebrated in a big way. It was well attended and people appreciated it. But heart of hearts, sir, I had a feeling, what are we doing? Who remembers the Mahatma anymore? People even ask, is he relevant today? Do we need him? His ideas are most impractical. When the whole world is going through a certain direction, if we're going to cling on to the Mahatma, what are we going to do? But that doubt got cleared when I came to know of this man. Give a hand to this man, please. He lived according to what Mahatma Gandhi wanted us to do. And he's a huge success today. He has been recognized by the government of India and many, many organizations around the world. About the service part of it, our child immortality, what it was in that area, what it is now, all the statistics I too have, but I should leave it to him to tell you all that. But what I'm trying to make out is Mahatma Gandhi continues to be relevant. Mahatma Gandhi is not impractical, he's highly practical. If this one man can make healthcare a people's movement, he doesn't depend on the government. He depends on the poorest of the poor. If you see some of those photographs, he stayed in a place for 7 years in a godown. And that was his hospital, his residence, everything, training ground, everything. He trained any number of women and made them as volunteers and sent them into the villages. He has adopted more than 100 and odd villages, I think. So it's a huge service, all in the name of Mahatma Gandhi. If this one man can do it, all of us can do it. No government can manage a country of this size unless every one of us contribute in our own little way for the well-being of the nation. Nothing much can happen. So we have here a person who is a great example. My only wish is the family, I should tell you, when you bring such people, these lectures must be shown live on television. Hundreds and thousands of people should see that even today there exists a doctor like this, who doesn't care for himself but prefer to go to the remote village, he and his wife, and for 30 long years he has been doing that. There's a lot more to say, but he has to say that and you're anxious to listen to him, and I'm also equally anxious to listen to him. Finally, I should thank the family. There's no service better than this service. In a democracy, you've got to tell the people that there exist such people in our midst. In these times, in this highly material times, there are such people of renunciation quietly doing great work. We have to project them to the world and motivate the youth particularly to take through this route, and that's the only way we can build a great nation. Thank you once again. Thank you very much.
Thank you, sir. Your speeches are always inspiring and always thank you for coming today. Young man, if you want to study economics, go to one of the villages of India, not to the US. As our chief guest said, these were the words told by Dr. Mohandas Karamchand Gandhi to Dr. Thakurdas Bang, the father of our chief guest, Dr. Abhay Bang. I now request Dr. S. Rajashekaran, Head of Department of Orthopedics, Trauma and Spine Surgery, to envision and enlighten the audience about this great visionary, Dr. Abhay Bang.
Good evening to all of you. Our orator, Dr. Bang, chief guest of the evening, Thiru Krishnaraj Vanavarayar sir, our distinguished elite citizens of Coimbatore, the family of Ganga who is on here, and ladies and gentlemen. Introduction of a person is always a formality, but when you have the task of introducing a person as eminent as Dr. Abhay Bang, then it's actually a proud privilege and honor. When I want to introduce him, I have a task of So I am at a perplexity. How would I introduce him? Should I introduce him as a brilliant academician who had a wonderful academic record, who stood first and got all the gold medals at every stage of his medical career? Should I introduce him as a great pediatric specialist, a very renowned academician in his field of specialization? Or should I go one level above, look at him from a distance as a Gandhian and a social worker, or a person who is a great public advocate, where he has stood for prohibition and also against the use of tobacco amongst women, or as a great influential thinker who is on the many boards of the government and actually has a big say on all the governmental policies. Even if I have to talk and focus on any one of the facets of this multifaceted personality, I would be overstepping the small time that has been given to me. Now, this is a proverb that which all of us know. You give only little when you give your possessions. You give fully only when you give off yourself. And this is something what Dr. Bang has done. This our chief guest already said. But what I would like to say is, when I was thinking about how a brilliant academician actually became a socialist, the answer lay when I was reading about him. And here again comes the saying that an apple never falls far from its tree. Now, as Mr. Krishnaraj Vanavarayar sir said, I think it is the genes that was working, 50%. That he was born to a person who listened to Gandhiji, tore his travel papers to USA, and then went back to the villages to learn the true economy of India. He and his brother spent their childhood in Gandhi Sevagram Ashram in Wardha with Mahatma Gandhiji's foremost disciple, Acharya Vinod Bhave. And even at a very early age, his brother Ashok Bang decided to work for issues related to farming, and our orator decided to work for the health of the villages. And today when I received him in the airport, I asked him, "Sir, how come after a brilliant academic career and after a stint in Harvard, you went back to the village?" He said, "Village was the agenda. Harvard was a means to serve better in the village." So this is something that was fantastic, which I learned. And if you learn more about him, and this is in one of the Wikipedias, so when he was studying for the final year exam for MBBS in Nagpur, he read an incident about Gandhiji where Gandhiji was very careful regarding the use of natural resources. After reading the incident, he decided to use the resources carefully. He switched off the fan in his room. He thought that he should be able to live without a fan. And he did not use the fan for the next 5 years during his education, even in the heat of Nagpur. Ladies and gentlemen, you know, in the heat of Nagpur, in the summer, it is 48 to 50 degrees centigrade. And so we have a man here who walks his talk. Now, Gadchiroli has been in the news for all the wrong reasons. It is one of the most least developed areas of Maharashtra and has always been in the news for the wrong reasons. It is the CRPF, the army, and the Moors always at tandem with each other, and there are always a loss of life on each other for this. Now, in this jungle, in this forest area, it was a blessing that it was like a lotus in the mud pond that Dr. Bang and his wife, Dr. Rani Bang, actually a great eminent person by herself, that they decided to live a life of austerity and selflessness and set up SEARCH, Society for Education, Action and Research in Community Health, and they brought up the health of that region very much up. When I wondered what made Dr. Bang what he is. I said 50% was his father, and it is not a secret that the other 50% is his wife, who accompanied on this journey of his selfless service right from the time of medical college when they loved each other and got married. To know more about her, on the academic side, I was really happy to know that she was one of the persons who was even proposed for the Nobel Prize a few years ago. But on the character side, you can see one of her quotes, "Keep your hand with the palm up and share all that you have to offer and let people choose what they want to take." How can anybody say anything much better in a much nicer way? So on this, that dedication, they both have influenced the health policy in India. He first brought to the notice of the world that rural women had a large hidden burden of gynecological diseases, and also showed how the pneumonia in children can be managed in villages, and recently how newborn care can be delivered in villages. And this has actually transformed the care of the neonates in the villages and also brought the infant mortality rate considerably. Now, this approach has become the national policy in India and also has been incorporated in the global guidelines of WHO. And they also established the famous community healthcare research center, Shodgram, and the tribal area. Not just in health, but in the wellness of the people. And that's very important to understand. He also led a campaign against alcohol, and I'm sure he has some interesting stories to tell about that. And in the area where alcoholism was almost 100% amongst men, he changed them so much that after the campaign of many years, it became the first district in Maharashtra. While the district was liquor taking, the state was liquor positive, the district became liquor negative, and prohibition was employed. He also studied and campaigned for the control of tobacco usage in women. And I'm not going through all these research in detail, but every one of them was not only high quality research, but also have a high practical impact in developing the health of this whole area. From that village, the research that they did, the findings that they did, had a global significance, and it has been included in the WHO guidelines in many. Naturally, he has got many brilliant academic positions. He is the adjunct professor, global health in Atlanta, adjunct and visiting faculty to the Indian Institute of Public Health in Delhi. And his current positions, I'm actually put only the top 5 that were there. There were more than 25 positions over there, including the high-level committee on tribal people in India. He is a member of the Audit Advisory Board, CAG, to Government of India, and many, many more, which just shows that the respect that even the government has on him and the influence he has on this. There are numerous positions that he has which are olden, and naturally for a person of this selfless service, there are always honors galore. And 2 years before, last year, he was awarded the prestigious Padma Shri by the government. And I think we should give a clap because the couple were, it is not just him. The Padma Shri was for the both husband and wife. And this is something that we have to do, of what people in love, they were just not in love with themselves, they were in love with the humanity by themselves. And this kind of love, what it can do to achieve, is a standing example for them. There are many more awards. He was also the Maharashtra Bhushan, the highest state honor of the government of Maharashtra. And I have put lots of awards which he has got from the government, from NGOs, from other distinguished academic positions, and also the international honors of Save the Children US Award for Global Contribution for saving newborns and children, and the MacArthur Foundation International Award for Creative and Effective Institutions. And it's also a pride to mention that the Time magazine recognized them as Global Health Heroes in 2005. So this is something is a precedent. Now we are very happy to have you here, sir. Thank you very much for accepting our invitation. Founders Oration is a time where we not only express our gratitude to our founders because they have given us a platform, a high platform on which we can perform highly and easily, but it is also a time where we have the opportunity to honor men who have contributed to our society and also to be inspired by them. And that is the aim, that to be inspired by them and so that we can perform better. And ladies and gentlemen, you will all agree with me that we could have had no better than the orator of today for this. Thank you very much, sir, and I request you to please accept the awards.
And how do I move it forward? This one? This one. Okay. Thank you. Thank you. Thank you, Dr. Raj Shekharan, for all those kind words and introduction, and Dr. Krishnaraj also. So actually, I feel little embarrassed to stand before you because I have tested their patience to limit. I was forced to cancel or postpone my coming here twice, but they were very kind enough and patient enough to tolerate my atrocities. And in hindsight, I think I would have missed a great if I had not come. Not only that, I had never been to Coimbatore. Since my childhood, I have been using khadi, and in the khadi field, Coimbatore khadi is very famous. So I knew Coimbatore for Coimbatore khadi, but today after coming here, in the brief time that I had, I could see a miracle that how in this Coimbatore city, a medical paradise has been created. In that 1 hour, I met patients from not only from Coimbatore and Tamil Nadu, but from Madhya Pradesh, and then from on one end from Afghanistan and another end from Bangladesh. So from Bangladesh, Afghanistan and Coimbatore, triangle, international triangle, and this institute stands there erect as a towering example of how dedication, commitment, vision, leadership, of excellent team, values and culture and science, when they all come together, what can happen. So I feel very humbled to see such a great institution and the great work that is being done here. I pay my respect to both the founders, Dr. Shanmuganandan and Mrs. Kanakvalli Shanmuganandan, not only for having started this as a small seed, but this has continued for 3 generations. often good initiatives continue with one individuals and then end. But this has taken root and now being transmitted to the third generation leadership. So I pay my respect to both of you. I congratulate Ganga Hospital, Ganga family, as our chief guest mentioned. It's a very good word, Ganga family. This hospital, its spirit, you enter the gate, you come inside and you start feeling the spirit in the behavior of all the staff, the culture. Peter Drucker once very beautifully said, in the business field, they often talk about strategy, business strategy. So Drucker said, and Drucker was a management global guru, and Drucker said that in any organization, culture eats strategy for the breakfast. The culture of the organization is far more important. It shapes the behavior, visions, goals. Everything is shaped by culture of the organization. Strategy, etc. are secondary matters. Peter Drucker himself is saying. And so I could feel that culture in this organization. So I am very happy that I am here standing before you. In comparison to this lofty word, what should I say? A lofty work. What should I say is a question, because my experience, my work is exactly of the other side. So in a way, I would say that what they are doing here and what we are doing in Gadchiroli are two complementary things, two sides of the coin, and society need both. So I have chosen because I knew that I will have audience of two types, one from hospital, other from Coimbatore city. So I'll try to present before you stories after stories. Though they are stories, sometimes stories of research, but still I'll try to talk in a less technical manner so that whatever I want to communicate in the end gets communicated. So I'll tell you a story, a journey of a research study, and I'll propose an alternative approach of research. Don't be scared, I'm not going to go in the technicalities of research, but I'm going to talk about research with the people. You already heard about this place. My life begins here. This is Mahatma Gandhi's Bapu Kuti, Sevagram Ashram. And as both of them said, he influenced my father. I once asked my father later on, not only he cancelled his US education on Gandhi's that sentence, but throughout his life, subsequent 60 years, he was working for Gandhian movement. He was national chairman of the Gandhian movement later on. So I asked him, what was the magic of the old man? He uttered only one sentence. He said in Hindi, अर्थशास्त्र सीखना है तो अमेरिका की बजाय भारत के देहातों में जाओ. That's all, only one sentence. And that changed your life. I asked my father, what was his magic? So my father thought a little bit, and then he said, he himself was 85 at that time. He said, when Bapu asked me to go to the villages of India, if he was sitting in Rashtrapati Bhavan at that time, I would have ignored him and I would have gone to the US. But when he asked me to go to villages, he himself was living in this village called Sevagram. His hut was like hut of any ordinary farmer in the village, and he was sitting on a bamboo chatai. So that bamboo mat became throne and his words became mantra. Power of Mahatma resided in actually living what he said. He was not a great scholar, but his life was a great book. He actually did, and that is actually often missing. We have all the university professors everywhere and the columnist writings in newspapers, very scholarly columns. But usually we get information from them, but we don't get inspired by them. The magic of Mahatma lay in his living what he said. So it's not at all my credit. Whatever I did subsequently, I was born when my parents were living in that village Gandhi had asked them to go. So it was my destiny, I should say. I had that inheritance that I should have been doing what I did. When Rani and I returned from the US, those words of Mahatma were still echoing in our ears. Go to the villages of India. And so we chose this place, Gadchiroli, at the eastern end of Maharashtra, nearly 1,000 kilometers from Mumbai. Not only 1,000 kilometers distance, but maybe 1,000 years distance also. Gadchiroli still used to live very happily in the past. The least developed, most backward, remotest, poorest district of Maharashtra. And so we thought that if anyway we want to serve rural areas, why not go where you are really needed rather than going where you are not needed and you have much more competition. It really means that you are not needed here. So we chose to go to Gadchiroli. This district is still covered by dense forest. This Gond tribe, can we put off the lights please? Is it possible? The colors will be better visible if it is possible easily. Otherwise leave it. Okay, fine, leave it. So this Gond tribe, it resides in the central part of India, and next to the Bhil tribe, Gond is the second largest tribe in India with total population about 1 crore, spread over in 5 states. In Maharashtra, it's located mainly in Gadchiroli district. About 1,500 villages, huge distances, no roads. Primitive paddy cultivation was the mode of food production there. So in the monsoon, 4 months, people used to work in their field, and rest 8 months, people survive by collecting various forest produce. This Gond woman has collected mahua flowers, which she would dry, and then they can eat it as food. They can also give it to cattle. It's used as cattle feed also, for medicine also, and also for producing liquor. This was the prevalent mode of transport, and even the sickest patients, mothers, children, had to be transported. If at all transported, they were transported in bullock cart, and intermittently you heard bomb blasts and Maoist activity. So the entire district was under terror. So poverty, illiteracy, malaria, terror, everything together, ideal place to serve. When we went to Gadchiroli, Gadchiroli was a village of 8,000 population. So local trader very kindly gave us this godown, and for 7 years, this was our base. This Tendupatta godown was our base. And then in the forest surrounded by tribal villages, we constructed our own village. We call it Shodhagram. I started my life in Sevagram, a village for service, for seva. We added Shodh to it. We added research to it. And so we named our village, where we all live for the past 30 years now, we have named it Shodhagram. So we have tried to add research to service. Gandhi's service and research that we learned from medical science and public health in the US, we have tried to combine them together. And so actually my journey has been from Sevagram to Shodhagram. Now what did we do in Gadchiroli? I am not going to tell you everything we did. It's a 30-year story, too long to be told in one lecture, and need not be told at all. But I have a particular theme in my mind today. So I'll discuss few experiences or few stories only in relation to that particular theme. When we went there, in the second month of our stay, this girl was referred to me, a tribal girl, 8-year-old, emaciated, pale, mild jaundice, liver spleen enlarged. She was sent to me as a case of rheumatic heart disease, but she didn't have rheumatic heart disease. So what was it? I suspected that she might be having sickle cell disease. Now till then sickle had not been established or reported in Gadchiroli, so I had to work with the lab people to establish the test, and yes, she turned out to have sickle cell disease. Sickle cell disease is a disease of blood, genetic disease, and this made us enormous curious, and remember, I had just come from the US. So you carry US influence on you when you come, so research, reporting, new cases. So I was very excited, and in that excitement, we conducted a district survey to find out what was the proportion of sickle in the district, prevalence of sickle cell. So 15% population had sickle gene. We collected blood samples from thousands of people, and the findings were reported by calling tribal minister, health minister, collector, MLAs, etc. And we reported to them that this district has high prevalence of sickle cell disease. In sickle, if you have one gene from one parent, you don't have any clinical problem. You are all right, no problem. It's only when from both the parents you get the gene that you have disease. So only small proportion of people really have problem. 98% people with sickle don't have any problem. So when we reported these findings, health minister said that, look, this is the beauty of voluntary organizations. Dr. Monk came here and within 6 months he found out a new problem. He did district survey and reported to us this huge problem. So in his honor, we will start a tribal medical research center in Gadchiroli. I was delighted. And this was published as a research study. I was delighted. And Maharashtra government gave me my first award, Tribal Servant Award, Adivasi Sevak Award. I was delighted. But nothing happened. That promised research center on tribal people was not opened in Gadchiroli, it went to Pune, where there are no tribals. But the researchers did not want to come to Gadchiroli. They wanted to stay in Pune. So the research center went where the researchers were, where there were no tribals. So we went back to tribal leaders, villagers, saying, look, we found this disease in you, and government of Maharashtra has cheated you, so you should do something. So tribals looked at us blankly and they said, doctor, did we ever tell you that sickle is our problem? You came and you asked us for a drop of blood. We thought a young couple has come, why disappoint them? So we gave you a drop of blood. We have nothing to do with this problem that you say you found in us. Sickle is your problem, you solve it. I had a lesson of life. We all who are trained in medical sciences, we aspire for research, but when we are doing research, explicitly or implicitly, we are really thinking about the research community which is spread all over the world. We are thinking that we will find out some new finding and then we will publish it in the journal. We will present in conferences. There will be claps. There will be acclaim. I will be accepted as a good researcher in the research community. But in that process, we alienate the very people whose problem it is. And that's why research becomes very powerless, impotent. It's because our approach of research is such that we monopolize the problem, or even we select a problem which people have nothing to do with. They are not concerned about that. But we think that this has potential to be published. So our whole approach to research seems to be wrong. We had a very introspective phase of frustration that after publication nothing happened, but we learnt a great lesson. That research should address the needs of the community I work with and not the research community I report to. In hindsight, I must tell you, I feel ashamed of this first piece of research of mine. I feel ashamed because I think we did research on the people. people had no problems with sickle. They were happily living with sickle. Actually, medical science tells us that having sickle is a partial protection against malaria. So people were blessed with sickle, but we turned that into a disease and research project and got everything but except the solution. So there has to be something very seriously wrong in a research approach which alienates the very people whose problem it is. And then finally nothing happens except for few publications, few conference presentations. There and then Rani and I decided for us research philosophy for search that hereafter we will not do any research on a problem which people don't require. And so since then we are experimenting, we are trying a different approach. So how do you know what problems people have? I was reading Ronald Ross biography. Ronald Ross person who found out working in Sikandarabad, he found out that mosquitoes transmit malaria. But when he was struggling with this problem and didn't find the solution, he had gone back to London from where he had done his tropical medicine. And after evening, after dinner, his guru, Patrick Manson Bahar, and Ronald Ross were taking stroll on the footpath of London. And young Ronald told his guru, this is the problem I am facing. What is the role of mosquitoes? And Patrick Manson said, my son, if you want to do research on mosquitoes, learn to think like mosquitoes. So if we want to do research to solve people's health problem, we should be able to think like them. But then why think like them? Why not ask them? They would be the greatest source. So Rania has started going to villages, sitting around night fire, because that is the time when people are free in the villages. The rest of the whole day they are busy. And around night fire, tribal start speaking because they feel very cozy, warm. And we asked them what were their problem, what kind of healthcare they needed. We asked them that government has constructed hospitals, but you don't go to hospital, you don't seek medical care, why don't you? So initially, after some reluctance, they said, look, these hospitals are multi-story, so we are afraid of multi-story hospital. Then they said that the doctors and nurses are wrapped there in white cloth, apron. So we asked them, what is wrong in apron? Why do you object? So the tribal said, we wrap dead bodies in white cloth. Here these people are already wrapped in white cloth, so how can they save anybody? So we don't go to them. And then finally they confided that, doctor, in those hospitals, you doctor consider yourself God. There is no God in hospital. If there is no God, there cannot be healing, so we don't go to hospital. So what do you do now? So we designed with them through a process of 6-month discussion, alternative idea of tribal friendly hospital, where the hospital was made of huts, no multi-story building. And tribal people should feel as if they have come to their own village. And at the gate itself, we constructed a temple of their goddess. And when this was done, and we wanted to name this new hospital tribal friendly hospital, tribal people suggested name Ma Danteshwari Davakhana. Danteshwari is their goddess, tribal people goddess. So I had not yet forgotten the US completely. So to me it looked very, very sort of a mundane traditional name, Ma Danteshwari Davakhana. Doesn't sound very fashionable, modern. So I told them that, look, let's think of some other name. So tribal women stood up and they said, look doctor, this hospital doesn't belong to Abhay Bang. This hospital doesn't belong to Rani Bang. This is our hospital. We have named it as a Ma Danteshwari Davakhana. What more a doctor can want than tribal people who were not willing to go to hospital, they saying that this is our hospital, we own it. And that's how our tribal friendly hospital was constructed 30 years ago. This is our hospital OPD entrance. At the very entrance, there is a room called Gotul. In tribal village, there is a room whenever guests come from outside, like a reception room, they have something called gotul, a hut called gotul. So our reception room was designed on the lines of gotul. This was hospital huts, but because there was surgical care needed also, we constructed 2 operation theaters, and operations have started. And Dr. Raj Shekharan's friend, Dr. Shekhar Bhojraj, has been coming there for the past 12 years and doing spine surgery also in that remote forest. Now, of course, whatever little medical work we do there in that hospital is nothing as compared to the great work and the huge work you do here. But our effort is to adjust, shape this hospital and the services to the culture of tribal people and the services they need. So how do you know what are their priorities? Having done the blunder of sickle cell priority, so we started inviting tribal representatives from 50 villages every year in what we call Tribal Health Assembly or People's Health Assembly. And there, 2 days we used to discuss what were their health priority, on what problems they wanted surge to work. After first Tribal Health Assembly, we actually conducted voting. Ballot papers were given. Actually, we gave 3 leaves to each person and asked them to put leave in a box. 20 boxes for various health priorities were put. So tribal people selected their own priorities, and look, these were the 5 priorities which came up. Malaria, low backache, white discharge amongst women, brother, alcohol and alcoholism amongst men, and then finally they said child death. Our children die. Can you do something? Now this agenda, research agenda given to us by the people, provided us lifetime agenda. For the past 30 years, we have done nothing more than trying to solve only those 5 problems. And actually, on each of these problems, there is a story, but I'll share with you only experience about child deaths. Now, when people said that our children die, can you do something? And one expected child mortality to be high in that area, so we selected an area of 102 villages. That area became our population health laboratory. And for the past 28 years, we have been very regularly measuring the complete population, every birth, every death, every cause of death in this population. It's one of the 22 such sites world over where such long duration of population-based records have been meticulously maintained. In the first year, we found, after we completed the first year's measurement, that the infant mortality rate was 121. Infant mortality rate, those who may not know, is when 1,000 babies are born, how many of them die within 1 year? That's called infant mortality rate. For example, in those days, Kerala had infant mortality rate of 12. I don't know what was Tamil Nadu's infant mortality rate now, but I guess it must be around 20. So Tamil Nadu infant mortality around 20, Kerala 11. Gadchuli had infant mortality rate of 121. And when we tried to identify what were the causes, why did children die in villages of Gadchiroli, pneumonia was number 1. Now pneumonia in children is relative urgency. A small child, let's say this child, 6-month-old, you can see it's malnourished, but it is panting. It has got breathing difficulty. So child with cough and breathing difficulty, this is usually the presentation. And if you receive antibiotic, most of them can be saved. If you don't receive antibiotic, a sizable proportion of them die. Antibiotics have been discovered 30-40 years earlier. Penicillin in 40s, and then subsequently several other antibiotics. But antibiotics never reached those tribal villages. And so antibiotics continue to be in the shops and in doctors' clinics and in pharmaceutical industries, but they didn't reach where children were dying without receiving antibiotic. Now, how do you stop pneumonia deaths in villages? Globally at that time, nearly 4 million children died of pneumonia every year. About quarter of these deaths occurred in India. So 1 million child deaths because of pneumonia every year in India, but doctors didn't go to villages and these babies never reached hospitals. Fortunately for us, a pediatrician from Australia, he went to another tribal area in Papua New Guinea and he did a simple piece of research and he found out that if a child has cough, you don't have X-ray, stethoscope, anything, how do you diagnose pneumonia? So count respiratory rate. In a child with cough, if respiratory rate in infant is more than 50, it is pneumonia. Most likely it is pneumonia. Now problem is in our villages, women even couldn't count up to 50. So I developed this simple equipment which I call breath counter. As you can see there is this sand timer and this is abacus. 2 rows, one for the newborn baby and one for the infant. Now this woman, her name is Yashodabai. She is from a village, she is a Dai, illiterate Dai from a village called Bodli. Now we wanted to teach illiterate women in villages to be able to diagnose pneumonia and treat because there was nobody else. How do you enable her to count up to 50? How do you enable her to use wristwatch? Again, she wouldn't be able to use. And how do you enable her to diagnose pneumonia? So all those 3 functions were combined in this equipment. When there is a child with cough, she wants to diagnose whether baby has pneumonia, she would turn this equipment upside down and the sand would start passing. She would look at the child and for every 10 breaths, women could count up to 10 because in earlier British period there was dozen. So they knew how to count up to dozen. Dozen means 12. And so for every counted 10 breaths, she would move 1 bead. Again start counting. For every 10 breaths, she would move a bead. If before the sand has passed, which means before the completion of 1 minute, if she moved the red bead, which was the 5th bead, if the red bead is moved, it really meant that respiratory rate is more than 50. She doesn't know it. She can't count up to 50. But if the red bead is moved before the sand is passed, it is pneumonia. With this equipment and this training, I compared on 50 children with cough. They diagnosed, they examined using this equipment and I using stethoscope and X-ray. And their diagnosis was 82% correct. So with this simple equipment could make an illiterate woman in the village 82% doctor as far as this one single function was concerned. And then in each village, this is sand timer, the larger view, and in each village we created such community health workers, initially illiterate Dais and then community health workers, and gave antibiotics, oral antibiotics in their hand, that if child has pneumonia using this diagnostic cutoff, treat with antibiotic. Before antibiotics were made available, those children who had pneumonia, 13.5% died. With this antibiotic and this simple method of diagnosis, the death rate dropped from 13.5 to 0.8%. And this is actually data up to 2003, but we very recently analyzed it up to 2018. The case fatality rate, death rate is now 0.5%. 1 child in 200 now dies. In these villages where we have conducted this experiment, we conducted a controlled field trial. The trial was published in the Lancet. But we have continued this as a service program for now nearly 30 years, and the death rate, case fatality rate, is persistently 0.5% or low. Even if I had treated These workers have treated so far 16,000 children with pneumonia. Every case record is computerized, it is verified, and after 7 days supervisor goes to verify whether child is alive or dead. Even if I had treated, I don't think my case fatality rate would have been so low. But they are able to detect pneumonia at the very early stage because the patient is next door from their own village. And parents are now convinced that this woman can treat pneumonia very successfully. So the care seeking is very huge. Our coverage, total estimated cases of pneumonia in those villages, 40 villages, 96% of pneumonia cases seek care from our sources, and the pneumonia mortality rate drastically went down. This study was published in the Lancet. Infant mortality rate with this one single intervention from 121, it came down to about 76. Not only this study turned out to be the world's first study, controlled field trial on how to manage pneumonia in children in developing countries, but later on when global pneumonia control program, it was called ARI, acute respiratory infection control program in those days, was designed, this study and 6 other studies by WHO became the main evidence based on which the global program was designed. So we learned that what people tell you are true priorities. People are not fools. Only problem is we don't go and ask them. We are in our medical arrogance that whatever intellectually stimulates me is the research problem. But when you ask people, you get the real priorities. And measurement is very crucial. Without measurement, you can't even know whether you have solved the problem or not. And the solution has to be given in the hands of the community whose problem it is. Now our infant mortality rate got stuck at 76. It wouldn't come down. For next 5 years, that infant mortality rate in that area continued at that level. We tried several things, but no solution. And then we realized that of the remaining child mortality, the largest component was newborn deaths. The first 28 days after a baby is born is called newborn period. This period is very risky. A newborn is biologically very fragile, most vulnerable, extreme end of the life, just beginning of the life, and there is no care available. So a rural newborn, biologically vulnerable, helpless, and these newborn, when they get sick, they can't tell you, doctor, I am sick. Newborns either cry, which is okay, but they stop crying when they are too serious and then they die. They give you not more than few hours to take action. And globally, nearly 9 million neonates used to die. In India alone, nearly 2 million neonates used to die. And here we were facing that global problem in Gadchiroli, how to save these neonates. Forget pediatrician, forget neonatologists, there were not even MBBS doctors. Even nurses didn't want to stay in Gadchiroli jungle or in those remote villages. How do you provide care to babies where they are? We studied how are these babies delivered and how is care provided at home. Most of the deliveries in Maharashtra at that time, rural areas, were home deliveries. This I am talking about 1993. So this is a home delivery room in a village called Murza. The smallest room, least ventilated, where there are no windows, no light, no ventilation, that room is usually selected for home delivery room. You can see the mother is still lying here on the charpoy. tired, dehydrated, emaciated, pale, she's exhausted. And this newborn baby, old woman who could be grandmother, who could be dai, is providing care, providing massage and bath to this baby. This baby is exposed, so exposed to cold that baby can become hypothermic, that can become cold. And look at this cow dung plastered floor and this cow dung dust to her soles. So baby's bare scalp or bare hand is hardly few inches away from billions of bacteria in this flooring. And 20 million rural neonates in India were born in these kind of home delivery rooms, and mother and babies were provided care in these kind of rooms, and tradition did not allow them to step out. Evil eye, black magic. So traditions meant that they couldn't step out that room, nobody else should go inside the room except for old women in the family. So even if baby became sick, nobody would recognize. So this home delivery room was almost like a black box. Black box of newborn care. We used to see babies in hospital, but sitting in hospital we never knew what was happening in those black boxes. 20 million. And whether newborns, they were born there, and whether they died or survived depended on what happened in that room. Medical science had not even reached those rooms, not even observed what was happening there. All our knowledge of pediatrics came from hospital, and the babies were born and dying at the home. So we decided to take this science to those homes and huts. These babies, even if they were sick, first, as I said, tradition didn't allow to go out, but even if suppose some family, enlightened family in Gadchiroli wanted to take baby to hospital, district is 300 kilometers long, and at that time there was only one place where some neonatal care could be provided. That's at the district hospital. Very poor quality, but yet at least something was available at the district hospital. 300 kilometer distance. And this mother and baby, they are not allowed to even step out of the room. So then, what to do? When China designed its healthcare policy in 1951, they decided one simple guiding principle, and a beautiful principle. They said, how far a mother on foot can walk with a sick baby in her arms, healthcare must be available within that distance. Such a beautiful rule of thumb, no measurements, nothing, no complication. How much that mother can walk on foot. And here, as we saw, she was not allowed to step out. So we said that care must go where the babies are. We should not wait in the hospital. And with that motto, we turned neonatology upside down. Instead of providing neonatal care in neonatal nurseries and hospitals, home-based neonatal care. Anyway, babies were at home. The question was, can we take modern science there, where the babies were? And so, the goal was to provide simple primary neonatal care in the villages by empowered women in the villages so that a low-cost model emerges. We designed the model concept, wrote the protocol, and conducted again a field trial. Because otherwise, how do you know whether your solution is successful or not? You can always pat your back and write pamphlet and brochures and saying that we have developed a new solution. But unless it is rigorously evaluated, tested by scientific method, and as Abhijit Banerjee got Nobel Prize for economic studies, now that RCT, randomized control trial, is something which even non-medical people know. So that kind of controlled field trial, 39 villages were selected for home-based neonatal care to be introduced. 47 villages were control villages. They were under government program. They continued as they were. 2 years of baseline and then 3 years of home-based newborn care. And then we would know really what is the net effect of home-based newborn care. Did it reduce newborn mortality? Now, how is newborn mortality measured? I told you about IMR, infant mortality. 1,000 babies born, how many die in 1 year? That's called infant mortality. Now 1,000 babies born, how many die in first 1 month only? That is called neonatal mortality rate, NMR. So we measured the baseline IMR and NMR in these villages. Baseline IMR was 76 and NMR was 60. It means 1,000 babies born alive, 60 died within 1 month itself in those homes. So with this baseline measurement, we selected in each village now one woman, educated, literate, I shouldn't say educated, literate woman to provide neonatal care in the village itself. This woman, her name is Kajubai. Kajubai is a 7th standard fail woman, a Dalit woman from a village called Ambe Shivni. We selected her for her passion, for her guts, for her desire to do something useful for her community. 39 intervention villages that I said, 39 women were selected from these 39 villages, one per village. And we called them Arogya Doot. They became our barefoot neonatologists of that village. Through a structured program of 28 days, we converted them into a village level neonatologist, if I am allowed to use that lofty term. Village level neonatologist. And in that role, she used to visit women, pregnant women, give them health education as to what care they should take during pregnancy. She would visit after delivery, she would attend the delivery if the baby did not breathe at birth. And about 5 to 10% babies don't immediately cry and breathe at birth, so they need some help, resuscitation. Then she would make 7 visits to every newborn baby within those 28 days. She would measure the temperature, measure the weight of the baby, ask mother about complaints. Here, Arogya Doot, a group of Arogya Doot, community health workers, they are learning to use what we call bag and mask, ambu bag. If baby doesn't cry within 30 seconds after birth, she would start cleaning and providing resuscitation so that baby should cry and start breathing. You hardly have 5 minutes at that time. If baby doesn't cry within 5 minutes, there is a risk of permanent brain damage. If baby doesn't cry within 10 minutes, it means baby is dead. Through a 17 steps algorithm, we taught them how to resuscitate baby. After baby is born, what to do second by second, and by the end of 30 seconds starts resuscitation. Just a digression, but then few months ago, Prime Minister Narendra Modi had a video conferencing with selected Ashas from all over India. And somebody showed me the video of that conference, that Prime Minister had dialogue with Ashas all over India. And one Asha from Jharkhand, she showed Prime Minister from Jharkhand, she is showing on video conferencing these equipments and told the story that how she saved a baby who did not breathe at birth. And Prime Minister was so happy. And then she had even actually brought that child, because that child was now 6 months old. So she brought and showed Prime Minister, this is the child alive. That method, origin of that method was the first time when we trained our Arogya Doot for birth asphyxia resuscitation. Then after birth, immediate breastfeeding, exclusive breastfeeding. 10% babies are preterm. 30% babies are low birth weight. They are vulnerable. So how do you keep them warm? They become cold in the winter. So to keep them warm, we had no incubators, often no electricity in villages. So we developed this kind of simple warm bags in which those babies would be kept and kept warm. And then we invited 10 senior most pediatricians of India. Look, because what we were proposing to do and training this community health worker to do was unheard of. Medical profession would have hanged me for having done this. Because newborn, sick newborn, if you looked at WHO guideline at that time were, and literally I am quoting WHO guideline, sick neonate is a medical emergency, don't even touch, immediately refer to hospital. Where was the hospital? Hospital was only a notion in Gadchiroli. And so we were violating WHO guidelines. By training this community health worker to provide care, it was issue of 20 million neonates in India. They had no access to hospital. And so, we invited this senior most pediatrician. Look, the man with turban was the chairman of pediatrics at All India Institute of Medical Sciences, Dr. Meherman Singh. Dr. Poddar was president of Indian Academy of Pediatrics and also president of Asian Academy of Pediatrics. So 10 such. Dr. Vinod Paul, who is now member of Niti Aayog, he was one of the member of this panel. We invited them and asked them to evaluate our community health worker and this home-based newborn care model that we were developing and tell us where we scientifically correct and where we ethically correct to give those neonates in the hands of these women. They evaluated our Arogya Doot, and at the end of it, Dr. Meherman Singh said that these Arogya Doot of Gadchiroli trained by search, they know about newborn care more than the medical graduates of All India Institute of Medical Sciences. And so you can very safely give neonates of Gadchiroli in their hands. And that's how it started. Here the same Kajubai whom you saw earlier, she has diagnosed newborn sepsis in a baby who happened to be her own grandchild, and she is treating it with antibiotic injection, which is part of home-based newborn care. Now, let me cut short the story. Let's look at the effect, the results. This is NMR, newborn mortality rate. 1,000 babies born, how many died within 1 month? The control area where the regular government programs continued as usual, their NMR continued at around 60 for 10 years. It really means that for 10 years, the rural neonatal care hardly changed in India. But in those 39 villages where we introduced home-based newborn care, the baseline NMR was 62. Within 3 years, it came down to 26. 70% less as compared to the control area. What does it mean? In the US, reducing NMR is one of the toughest frontier, or anywhere in developed countries, that is the most difficult frontier now in pediatrics. If NMR reduces even by 5%, it would become national news. And here in Gadchiroli, it reduced by 70%. And look at the effect on infant mortality rate. It was 121 to begin with. With pneumonia treatment, it came down to 76. With home-based newborn care, it reduced and reduced and reduced and came down to the level of 30. Gadchiroli villages continue to be remote, continue to be poor and inaccessible. And yet, these women have reduced infant mortality rate from 121 to 30, and mere coincidence, but in 2003, this is in 2003, new national policy for India was decided, and the government of India decided this as the target. Reducing IMR to the level of 30 became the national goal. Who did this miracle? Now these 4 women did this miracle. Mother, grandmother, Dai, and this trained Arogya Doot. They have saved these twin babies. One was 1200 gram, another was 1400 gram baby, but by way of home-based newborn care, they have saved this baby. Now look at these women little more carefully. What is special about them? What do you see? The special about them is that there is nothing special about them. They are as ordinary as any woman in the village. And we have crores and crores of such women in villages. Only thing that they are disempowered. Nobody gives them simple knowledge. What is happening inside your uterus when you are conceiving? Nobody tells them that what does your baby require? But give them knowledge, give them power, and they do the miracle. And not only in India, but you have this kind of women in Bangladesh, in Pakistan, in Nepal, in Africa, in Bolivia, in South America. Problem is everywhere and the potential solution is also everywhere. And what does it need? The Arogya Doot has these equipments, simple equipments, not very high-tech or exotic equipments, but weighing machine, thermometer, this bag and mask, cotrimoxal antibiotic, vitamin K injection, and this record. It is same Kajubai whom I had shown you earlier, but this is 20 years later, so her hair has become grey. No, these are the equipments that, and all those equipments of home-based newborn care can be carried in a shoulder bag. So with this shoulder bag, with the equipments inside, with knowledge and training in her head, and with skills in her hands and compassion in her heart, this Arogya Doot literally becomes a mobile NICU. And I am not exaggerating. She can go to any home and hut and turn that home and hut into a secondary level newborn care unit. National Neonatology Forum of India has compared newborn mortality in 13 secondary level hospitals in India and home-based newborn care in Gadchiroli. Case fatality rates at the various levels of gestation and birth weight are comparable. She cannot, of course, provide tertiary level of care, but she can provide care which can serve as good as a secondary level hospital. And in secondary level hospital, the AIMS, All India Institute of Medical Sciences, has estimated the cost of NICU in secondary level hospital per day ranges between 6 to 12,000 rupees per day. And you have 20 million rural neonates. And so, at the very low cost, if you want to provide care in every home and hut, she is our response to the problem. This is the logo of home-based newborn care. Look, this hut was dark, that woman was helpless, but you open this one window of knowledge and that woman becomes empowered, and on her empowered hands, arms, she can take care of the family and also take care of the baby at her bosom. Empowerment is the crux. Transfer of knowledge, transfer of roles, transfer of skills. And we already saw those 4 women. We know such women exist in every village of India. Give them some opportunity. And they can do the miracle. This study again was published in the Lancet as the world's first field trial of home-based newborn care. Not only it was published in 1999, but later on in 2005, Lancet decided to select the best ever papers published in 180 years history of Lancet. And they were called vintage papers from the Lancet. This special volume was published. If you glance through that volume, in 19th century, in 1860, you find paper by Louis Pasteur, and you find papers by Robert Koch, discovery of tuberculosis bacteria. And in 1920s, you have paper by Benting and Best about discovery of insulin. In 1940s, there is paper by Alexander Fleming on discovery of penicillin. And you come to 1990s and there is a paper from this obscure place called Gadchiroli, paper home-based newborn care. So this method, because of the rigor of the science, though we were working in villages, the scientific rigor was not compromised. And so Government of India, I'm cutting the story short, this approach was replicated by us in 7 different places in Maharashtra to see whether it works. Then Indian Council of Medical Research replicated it in 5 states. Everywhere it reduced IMR somewhere around to the level of 30. So Government of India sent a special team from Planning Commission, and this was selected as a national model to reduce child mortality in India, and incorporated first in 11th 5-year plan, then in the 12th 5-year plan, then National Rural Health Mission. And we were asked to design training for 8 lakh Ashas. Now it was gigantic task. We had trained 39 Arogya Doot in our villages, then about 100 Arogya Doot in Maharashtra, but we converted that into a training science and prepared training modules for Ashas, training manuals for their trainers, and video material so that skills could be taught. And this entire set of training, 26 days of training, was first transferred by search to 500 national and state trainers, which were selected by Government of India. Then they in turn trained 5,000 district trainers, and district trainers trained 8 lakh Ashas. Today, about 800,000, 8 lakh Ashas have learned home-based newborn care, and it has been introduced all over India, in all states except Kerala and Tamil Nadu, because Kerala and Tamil Nadu really don't need it. The IMR in Kerala, Tamil Nadu was already so low. It's a compliment to Kerala and Tamil Nadu that the IMR was already so low that where in home-based newborn care reduces IMR to the level of 30, but in these two states it was already less than 30. So we decided that it will not be introduced in Kerala and Tamil Nadu. Rest, all over India, all states it has been introduced. Last year, Health Ministry informs me that 11 million, 1.1 crore rural neonates received home-based newborn care delivered by those Ashas. WHO and UNICEF published global guidelines, and they changed their guidelines from the earlier guidelines that if neonate is sick, sent to the hospital. The guidelines were changed that if hospital access is not possible in developing countries, home visiting and care at home by trained community health worker is an accepted alternative. The current WHO Director General, Dr. Tedros, he was earlier Health Minister of Ethiopia. When he heard of this, that something has happened in Gadchiroli which reduced pneumonia mortality and newborn mortality, he sent a very high power delegation from Ethiopia to study it. Then he asked us to train their national trainers, and then it was introduced in Ethiopia in 2006 onward. Currently, the WHO Maternal and Child Health Chief has written an article in which he mentions that this home-based newborn care in modified forms or other, depending on the local situation, but it is now practiced in 80 countries over the world. And so what that Asha from Jharkhand showed to the Prime Minister was outcome of this national scale-up. So I shared with you a story of a problem and its attempted solution from Gadchiroli to global. The problem was identified by listening to people. People gave us the problem. If I am not boasting, let me tell you another story. Few years ago, when I presented home-based newborn care at WHO headquarters at Geneva, the chief of maternal and child health there said, Dr. Bang, how come is it that you are able to find out a problem 10 years ahead of us? And this was happening third time. First we discovered gynecological problem in rural women, then pneumonia treatment, then home-based newborn care. So he said, how do you come to know of the problem? It takes us 10 years to know. So I said, I don't think we are anyway more intelligent than you. Only difference is we are 10 years nearer to the problem. And that makes such a huge difference. If you are nearer to the community, you can see before your eyes problem originating. And if you ask the people, you showed, Dr. Rajshekharan, you showed that Time magazine, Global Health Hero honor that they gave us. When the editor of Time magazine wrote story on us, he I must say, very thoughtfully, he titled our story as The Listeners. He said, high-tech medicine, he said, we also practice in the US. There is nothing new about it. But you listen to the people. That is the difference I have seen. And so he titled it as Listeners. So gradually to global. And this approach has continued. We keep on asking people. When people tell us priorities, we collect data, we do epidemiologic studies, we identify priorities, and then again try to develop solutions. The aim of the solution is that the people should be empowered. If the problem solution remains in my hands or in the hands of few doctors, there will be always limitations of its spread. And if the problem is very common, if problem is rare, then fine, few doctors can manage it. But if the problem is as common as newborn mortality, infant mortality, pneumonia in children, low backache, we need solutions which would empower the people. Today, non-communicable diseases are increasing in India. The figures vary, but about quarter of the adult population has got hypertension. About 5 to 10% of the adult population has got diabetes. This number would run into the crores. Where are the doctors to every month check blood sugar and BP of crores of patients and give them medicine? So we need solution in which people are empowered. And that approach, few years ago, actually when we had just returned from the Hopkins, I had gone in Delhi to a place called Gandhi Peace Foundation. And I was introduced to an old man there. Funnily, that old man looked little like Mahatma Gandhi. So he was told that he is Abhay and he grew up in Sevagram Ashram and he has come back from the US. So old man looked at me little skeptical and he said, Abhay, so you have studied public health? I said, yes. What is Indian definition of public health? I was flabbergasted. I knew WHO definition of public health. We all, most of the medical people would remember here, physical, mental, social well-being, etc., etc. I blurted it out. He said, rubbish. This is European definition. Tell me Indian definition. And I had to admit that I didn't know Indian definition. I didn't even know that there was an Indian definition of health. So he said, now I hope that because these words that I am going to use come from Sanskrit, so many of you will be able to understand. He said, what is health called in Hindi or in Sanskrit? Swastha. We call Swasthya Ministry. Health Ministry is called Swasthya Ministry. Swastha means healthy. He said the very word itself gives you the definition. How? One who जो स्व में स्थित है वो स्वस्थ है. One who is based in himself. One who is not dependent on others. That is the definition of swastha. There are comparable words. One who is sitting, let's say, one who is in the sky is called akashastha. One who is in the water is called jalastha. Similarly, swastha means one who is situated in himself. One who is dependent on others is called aswastha, sick. What a beautiful definition. And it gave us direction that if we want India to become swastha, it cannot be a doctor-based, hospital-based approach. For some severe sicknesses, advanced sicknesses, you will definitely need doctors and hospitals, no question. I am standing here because my angioplasty was done, otherwise I wouldn't have survived. So you do need high-tech hospital for certain episode, but for most of the common problems and population level problem, we need approach of swastha. When people would become healthy themselves and they will be empowered to take care of their health. Mahatma Gandhi, his dream of India was India should have, after Swaraj, India should have Gram Swaraj. Each village should be self-sufficient, should be able to fulfill most of its need by itself. So I borrowed that word from Mahatma Gandhi, and we have coined for us, the vision is Arogya Swaraj. Health, not dependent on hospitals and doctors and government. Health should be in hands of the people. Swa. I should be able to take care of my health, starting from prevention, my habits, health education, primary prevention and primary management. I should be able, if I cannot, my community. There should be at least one person in the community who can manage commonest problem, and maybe 10% more serious, more high risk, rare problem go to hospital. So Arogya Swaraj is the dream, not health empire, not the insurance companies providing insurance that so that you can live any way that you want and fall sick and somebody else pays. Using that model, US health system is almost at the brink of the collapse. Today, per capita annual health expenditure in the US is $9,000. And 17% of US GDP is spent on medical care. India spends something like 5 to 6% total, government and private combined together, 5 to 6% of GDP. American GDP itself is 10 times more than India's GDP, and then in that they spend $9,000 per capita per year. We cannot follow an insurance financed, hospital based, doctor dependent model in India. India would be bankrupt. McKinsey company has made projections about US cost of healthcare, US and Europe both. They presented it at the Davos conference. McKinsey estimates that the way cost of medical care is increasing and the way science is discovering newer and newer technology, and once something is discovered, people ask for it. So doctors, medical industry, hospital industry provides it, the cost goes up and up, astronomical cost. So McKinsey estimates that by 2050, the US will be spending 45% of its GDP on medical care, and by the year 2100, US will be spending ridiculously 97% of its GDP on health care, which is impossibility, but that shows really that the current medical care model that we are imitating from the US is neither desirable nor possible. So we need a healthcare model where people become empowered so that as far as possible they maintain their health, they take care of their health, people's health in people's hand. That's what we call Arogya Swaraj. So we are repeating same approach now to stroke, to hypertension, to tobacco and alcohol addiction. In the end, I wish to discuss few questions with you because there are several young people, researchers also, young doctors here. Because knowledge has become now the new form of wealth. Gone are the days when land was the main wealth. Today, knowledge is the main form of wealth. That's why Google and WhatsApp and Facebook, everybody hoards information from our lives because they sell it. Knowledge is the new wealth. And so how we conduct research is very important. It is almost like earlier wealth was generated by land or later on by industry. Now wealth is generated by knowledge industry. How we generate knowledge will decide where the wealth will get concentrated. And so research is very important. India has to do research. We have to do research on health problems for our country. So if a young researcher asks me, where should I do research? Somebody is fresh back from US or from high quality medical college in India and ask me, where should I start working? I want to do research, where should I do research? I would suggest to him, go where the problems are and not where the facilities are. Most often when we choose a place of working, we look for facilities. TV, mobile connectivity, air conditioning, film theaters, good colleges and schools. We want to go where the facilities are, but the places with facilities don't need you. There you become a problem. Better go to the places where there are problems. There are no competitors there. You are the pioneer. There is nobody else. Nobody else is willing to come there. So go where the problems are and not where the facilities are. Places with facilities don't need you. You become a problem there. So that's my first advice to young researchers. There are few young people here, that's why. How should I identify research problem? Usually in our medical community, the usual way is go to the library, look at the journals, find out what other people have done, what is missing, and then you decide your research problem. In this approach, we invariably end up with doing what Americans did 30 years ago. They have already done it, but I do again that research, I repeat it, and that's why very meaningfully we call it research. Because I am searching what has already been searched. It's better to go to the people and ask for the problem. Listen to the people, and I have already shared with you that how people gave us 5 problems which have provided us lifetime agenda. Listen to the people, observe people's lives in the communities, collect factual data on people's lives and health, and you get a problem. How should I conduct research? My methodology? There is a serious ethical question about research methodology in medical field. If this photo, if you recognize, it is a very world famous photo. There was a famine in Ethiopia in early 90s, very severe famine, and this photographer had spotted this very malnourished child almost at the verge of death due to starvation, and this vulture is waiting. Now this was published on the cover page of the Newsweek. This photographer got internationally best photo of the world that year. But the real problem started. He had severe problem of consciousness that what did I did with that child? He left that child. He felt so guilty that that photographer after 6 months committed suicide. Real ethical problem. You take photograph of a child but you don't do anything, you just get international recognition and awards, but the child dies. Are you justified? I am ashamed that we did that piece of research on sickle cell disease where people did not get any benefit. They didn't need it. We needed it for our publications. We needed it for our intellectual itch. People neither needed it nor were they benefited by it. They were kind enough to give us a drop of blood. So that kind of research I would like to call research on the people, where we use people almost like guinea pigs for our sake. We get grants, we get publications. Researcher gets publication, grants, career growth. What about the people on whom the research is done? And so, we are trying in Gadchiroli to evolve an alternative approach of research, which I would like to call, can there be a research approach by which people also are enriched and empowered? They become true partners? This I would like to call research with the people. Not research on the people, where they are used as guinea pigs, but research with the people. In research with the people, people should need it. People should understand it, what is being done with them. People should participate in doing it. People should use it, and people should own it. If knowledge is the new wealth, and we are conducting research on people's health, whose wealth should it become? It should ultimately be handed over to them, not to the pharmaceutical companies or medical diagnostic companies. But it should go back to the people's hand. It should empower their hands so that they can take care of their own health. Arogya Swaraj. Final question. But will this kind of research produce impact? We already saw that in Gadchuli it did. Long ago, once Archimedes told his king, 2300 years ago, he said, "O king, give me a liver long enough and a place to stand outside the earth. I promise you to move the earth." Of course, everybody laughed. The Archimedes shriveled old man's arms and he was boasting that he would move the earth. But we now know from the principle of liver that if you really have such liver long enough and if you have place to stand outside earth, yes, why Archimedes, even a child's hand can move the earth. That is the principle of liver, the length of liver. It provides the... We have discovered such Archimedes liver in Gadchiroli, that is research with the people. And we saw that research done there in that remote, obscure place Gadchiroli, known only for Maoist activity, but the knowledge generated there time and again. We fire those knowledge guns from Gadchiroli and they shake Geneva and London and health policies in Washington and in Delhi. You don't have to go anywhere. That is the beauty of the knowledge. That is the power of knowledge. In today's world of knowledge, world of science, if something is proved somewhere scientifically, it produces its impact globally. And so if you produce some methods by which people become empowered as far as the health is concerned, we already saw that knowledge from Gadchiroli spread to 80 countries. So research with the people can be the lever that ordinary men and women can generate knowledge, can generate power, which can move the globe, which can move the earth. Like we have our Vedas and Upanishads, China has its ancient book called Tao Te Ching. There is one beautiful ancient poem in Tao Te Ching, where the Guru says, "Go to the people, live amongst them, learn from them, begin with what they know and build upon what they have. And when the work is done, people say, we have done it." Beautiful guidelines. In Gadchiroli, we have done nothing more, nothing less. Thank you very much.
Thank you, sir. It was indeed awe-inspiring that in this age of modern medicine and modern research, simple methods like just listening to people and empowering them are the solutions to complex medical problems. On the behalf of Ganga Hospital, we thank you for delivering the 7th Founders Oration, and we invite now our chairman, Dr. J.G. Shanmuganathan, and Mrs. Kanagavalli Shanmuganathan, and the chief guest for today, Dr. Krishnaraj Vanavarayar, and Dr. S. Rajasabhavati and Dr. Rajshekaran, to hand over the plaque of appreciation to Dr. Abhay Bang.